I think your husband will agree that if you get this shot, then he would be happy to pay for
He'll
that.
pay for it.
He'll pay for it.
Listen, that's what you want to be promoting here.
Absolutely.
Give this to your husband, give this to your partner, to your significant other, whatever that is. And because, they're going to pay for it because they're also going to benefit from.
They're going to benefit as well.
Welcome everyone to VNEW Voices, powered by Arms Medical, where we explore transformative solutions in women's health through insights from top experts in the field. Today's episode is brought to you by Zyve 7, digestive and gut supplement dedicated to advancing wellness from within. I'm Robert Greer. I'm thrilled to be joined by Dr. Andrea Pezzella. She's a trailblazer in urogynecology who has been at the forefront of advancing care for women since 2010. In this episode, we're going to take away 3 key insights. First, you're going to learn how Dr. Pezzella creates a safe space for patients to share deeply personal concerns about their health. And second, we're going to explore the importance of addressing pelvic organ prolapse and similar conditions early to improve those outcomes. And finally, we're going to wrap it up with my favorite, some of the most advanced technology for pelvic healthcare and how it's transforming women's lives. So if these topics resonate with you, don't forget to hit the like button, subscribe to VNEW Voices, and share this episode with someone who might benefit. So let's dive in. I want to welcome Dr. Pezzella. And, first and foremost, let's get started with something that is really important in your field of treating patients with pelvic organ prolapse and incontinence, and something that is, really deep and personal. You are in the South, and it's an area that people do not talk about, and that's about their pelvic organ prolapse. I'd love to get your insight of how you help those patients feel comfortable enough to open up, because it's pretty personal and it's intimate. So what's your technique, Dr. Pezzella?
Well, hi, Rob. Thank you so much for having me on your podcast today. I'm really excited to talk about and share what I feel is really warm and, what I'm very passionate about and close to my heart, dealing with women with pelvic floor disorders. And so for me, yes. So I moved to South Carolina in 2007, and that relocation and learning a whole different type of demographic was somewhat daunting. And I was up in Massachusetts. I think there was a very mainstream, educated patient population. They very saturated in urogynecology. So coming down here and seeing sort of an underserved patient population, to me, I really wanted to share what I could do for these patients. So in 2010, I opened up Southern Urogynecology, a state-of-the-art center for pelvic floor reconstruction and incontinence. And for me, I literally went out there and hung up a shingle so that I could offer services to women in my community that had these issues that they really didn't speak about. No one talked about pelvic organ prolapse.
They didn't even know what a urogynecologist was, right?
Yeah, they had no idea what a urogynecologist was. And so bringing urogynecology here was really something that I felt that really changed a lot of this area. We definitely had, urology presence, gynecology presence, but as far as the expertise in pelvic floor reconstruction, I think they were lacking. So
let me pause there. It's because I know we brought up a unique term, right? It's a little bit more common, but urogynecology, you're in a underserved area for your specialty. What's unique about your specialty, and then how do you obtain those credentials so that women understand, like, hey, if I'm going to go to a urogynecologist, this is what they've done to get to this point.
Right. So as a urogynecologist, I'm specialized in obstetrics and gynecology. But then you subspecialize in a field where it's concentrated on women in your urinary and pelvic floor disorders. So incontinence, bladder prolapse, other pelvic organ prolapse, which is like the uterus or the rectum. Basically, things that happen after childbearing and over time as women get older. And so these are a lot of syndromes that they suffer from postmenopausally as they age, just from just wear and tear on on your pelvis. And so it's a training separate from, so a fellowship trained um, gynecologist specializes in the treatment for these types of conditions.
So how
And
long
so
is that fellowship?
it's usually it's 3 years.
Okay.
And so I did 2 years. I was sort of like grandfathered in. He's early on in the days. Now it's
Right.
3 years. And so you're fellowship trained, and then there's board certification. So the board certification was started in 2014. So you can be board certified in obstetrics and gynecology, and then board certified in urogynecology. And so these are your credentials. So we're urogynecology and female pelvic surgeons. And so the conditions of urinary incontinence, pelvic prolapse, and extends into genital urinary symptoms of menopause, vulvar conditions, pelvic pain. So there's such a broad spectrum of different conditions that we treat as the specialist versus your OB. A lot of women go into their OB to have their babies and then go annually for their pap smear. Their OBGYN may end up doing their hysterectomy. Some gynecologists still do some pelvic floor reconstruction, but it has really changed and it evolved to where the urogynecologists are really covering those conditions because we have the expertise and we have the surgical training. And because of the whole change with the mesh controversy in pelvic floor reconstruction, I think there was a lot of gynecologists that have been gun shy to offer whether it's graft or mesh reconstruction because of all the litigation and all the risks and complications associated with mesh. So we are
the experts, right?
we have so we are the experts. We have the training, the skill set, and the experience, and we're offering those different treatment options. So that's where I'm separated from the OBGYN. Of course, patients get really confused because they don't understand, because I'm a gynecologist and a urologist, but I don't do kidney stones. I don't do, bladder cancer. So it's sometimes a difficult discussion because patients really aren't sure what we're doing. So we're a little schizophrenic when it comes to what we do.
Great way to sum it up, right?
Yeah.
If you're a woman and it's happening in between your legs,
yeah,
you are the
yes. I say I'm waist down. My husband's an interventional cardiologist. I say he's waist up, I'm waist down. It's pretty easy to explain.
Exactly. So it's not dealing with the baby, right? Because those
not dealing with the baby.
Your OBs.
They asked me to do their pap smear. I tell them that your general gynecologist or nurse practitioner or your family practitioner can do that for you. I'm gonna do your surgery and then send you back to your primary care doctor or your gynecologist who referred you to me. I'm a specialist in those conditions. I will treat you, and then usually you can lead the practice. But we have kind of a unique practice where we're doing all of comprehensive women's health. So we're finding ourselves with my nurse practitioners in place, seeing those patients afterwards, and they do want to come in for their annual examinations, and they want to come in for their hormone replacement therapy and their intimate wellness, and they want to, because we sort of, take a deeper dive into their whole pelvic floor wellness by offering them other treatments. Yeah.
We can't talk about that right now because that is landing in the program.
Okay. Sorry.
That's all right.
Sorry.
I love it.
Spoiler alert.
That's a teaser, right? For everybody. We're going to get to the really innovative things that you're doing toward the bottom of the show. So you've been able to manage to, get people to open up. You've been able to manage to, talk about things that are, personal in their lives. What is the, probably like, what's walking through your door? What is, because, women sit there and go, this is just a me issue, right? This is just happening to me. No one else is feeling this, right? They're not really sharing that amongst each other. All right. So like, what's walking through your door so that when a woman listens to this podcast, she'll like, oh, I have that. I need to go see a specialist like yourself.
So sometimes women don't really know. They feel something uncomfortable, pressure, and they tell their primary care doctor and explain what's going on, or they actually feel like they're sitting on something. And so they have these nuances of symptoms that they're really not sure. Maybe they're going to the bathroom often, or they feel like they can't go to the bathroom completely. They feel pressure. They feel this uncomfortableness in their pelvic area. And so they come in with this sort of unknown, with this fear. And we make it a very comfortable environment where all women, where the center is, very kind of spa appearing. We have the lavender walls. We have the landscape of the waiting room where it's, very pleasing and comfortable. And they just kind of like come into the office and they have a lot of that fear is taken down. And then they come into the office and I explain to them that this is a very common condition. You're not alone. There are, and I tell them there's hundreds of thousands of women that have this problem, but not a lot of women have the symptoms. So we walk through, and depending on, what they're experiencing, we walk through some of the different types of conditions. And then obviously they do have to have a pelvic exam that day, and they are given a letter before they come in outlining everything that's going to happen that day of the examination and that day of the consultation. So they're well aware that they're going to have an exam. And then after the examination, I explain to them everything that I've evaluated them, whether it's their skin condition, whether it's their prolapse and what type of prolapse. And then we go through diagrams and we show them their condition through very elaborate diagrams. And then it kind of really spells it out for them what's happening to them. And I tell them that this is normal. This is a normal part of, and everybody's, on a spectrum of how they're different. Some women they may have this, but they don't have any symptoms. So one of the things that sort of pushes the envelope, if you will, is that they're having urinary symptoms, if they're having incontinence, or they're having bowel issues and they can't evacuate their bowels easily, or they're just feeling like they're uncomfortable, or they're having painful intercourse. So these are all the things that we really kind of uncover what's going on when they come in with this condition. And then we talk to them about options, and where we really can give them, again, on the spectrum, very conservative options, and then manage them with some definitive surgical options. And so that's where it makes them even more comfortable, because they're not just coming in and this person's going to operate on them. We really outline a variety of things for them, so it's a shared decision-making process with the patient.
You got the surgical on one side, you have the non-surgical on the other, yeah. And your office is certainly beautiful, fantastic.
Thank you.
It absolutely gorgeous.
Yeah, I'm very proud of it myself.
And it makes you feel relaxed, and it's not intimidating, right? It's not cold, and it's not like your typical medical buildings that a lot of times you have to experience.
Absolutely. You're not just a number. You're sitting there, with other women that are sharing the same thing. In fact, sometimes they start talking in the waiting room about their issues or what's going on, or they, a brochure or something kind of prompts a discussion. If you want
a quick peek, though, if you want a quick peek at your office and your staff, What's your Instagram? Because I've
Yes, so it's
that
SU Wellness Aesthetic. And so you can find us on Instagram, Facebook,
because
TikTok.
you guys are like really fun on that.
Yeah, we have a good time.
You have a good
It's
time.
we're there's an education piece where we're trying to educate patients on the things we do, and then we just want to have some fun. And I think that kind of lets just show everyone that it's not an intimidating thing to have to go through. This is something that a lot of women can share with us, and so we're not an intimidating place to come. And we'll be like your next door neighbor or your friend to be able to talk to about your issues. Yeah.
All right, so let's take a quick moment to thank our sponsor, Zyve 7. If you're looking to improve your digestive and gut health, Zyve 7 is the trusted supplement that can help you feel better from the inside out. And while you're here, don't forget to hit the like and subscribe button. If you like what Dr. Pezzella has shared on this episode, share it with your friends. And of course, we're going to have more valuable conversations coming up in the next moment. So, Dr. Pezzella, we were talking about this list of non-surgical options because I've been in your office and you have a lot of gadgets, we're going to talk about here soon. And then you've got the surgery side, which I'm very familiar with, and because you're going to be treating some of those conditions surgically in the hospital. So let's first talk about the surgery side, because then I think some of the other things that we're going to talk about is going to lead right into some of the technology that you're using. So from the surgery side, we've got we've got stress urinary incontinence, we've got pelvic organ prolapse, you might have having to do a hysterectomy. You've got some other conditions that they're dealing with, possibly like the constipation side of things, just laxity, a lot of different, minor things that kind of encompass, let's just say, your bulge or your leaky bladder. And of course, some of those things are mixed into it because they're all connected. What is, what's your technique, or how do you kind of work through that algorithm to say, hey, these are the things that you're experiencing, and from your professional experience, this is the pathway that I believe will give you the best outcomes.
Right. So when I'm speaking to a patient about surgical options, I go through the whole scenario. I actually explain to them, what their condition is, whether it's a dropped bladder, dropped uterus, dropped rectum, or cystocele, rectocele, uterine prolapse. And if they have any kind of urinary incontinence. And then there's different types of incontinence that we talk about as well. So then we outline each, we sort of segment it, each condition and how it's treated. And so I explained to them there's multiple procedures that we can do at one time for support of each structure. And so I outline, if say they have uterine prolapse, for example, and they are, a candidate, particularly if they have all 3-compartment prolapse, they may be a candidate for a robotic laparoscopic surgery that requires doing a hysterectomy. And then we can use a graft, a Y graft, mesh graft, that can then deliver support. So we can deliver that in a sort of a 3-dimensional reconstruction. And we do it through small, little tiny ports in the abdomen.
So if you're gonna be taking them back, and you're gonna be using what they term in the lingo for the women, it's like, okay, we're gonna use the robot, right? So we're gonna utilize a robot. And we're gonna take this piece of mesh, and it's gonna be shaped like a Y. It's gonna be about this long, and it's been used in the space for probably over 20 years, right? Hmm. And of course, that the job of that mesh is going to lift their apex, their top of their vagina back in its place. right? And with that, then you're going to have some other compartments that you're going to deal with.
Right. And I explain that to them through, diagrams. I draw very, rudimentary drawings so that they understand how we're doing that. And I tell them that this is the gold standard. This is what we do because, of course, you say graft or mesh. They get very intimidated. They question the risk factors associated with that. And I go through the evolution of using different types of meshes and where we've come to this point, and whether it's transabdominally placed versus transvaginal. And so I try to break it down and simplify it so that they're, allay their fears and explain to them this is a permanent supportive way to reconstruct fully a 3-compartment type of prolapse. And so that is one option. And I kind of, I go through the dialogue, depending on the age of the patient. Certainly that's a factor. Their sexual function is a factor. Other medical morbidities is a factor. So that all plays into kind of which way I steer the patient. If she's, older, not sexually active, has other medical issues, or has some, weight issue, she may not be a good candidate for a laparoscopic robotic, where we want to stay sort of out of the abdomen if they've had previous bowel surgery. Then we talk about a vaginal approach, which we're, very, well trained on as well. The only thing is now we do not have a transvaginal mesh to offer. So I talk to them about what we call native tissue repair. And I go through the scenarios of how we reconstruct the vagina, the apex, like you mentioned, the top of the vagina, with either support sutures to the ligaments that they were once attached, or we reattach your connective tissue to the ligaments we find deep in your pelvis. And so these are the ways we kind of describe and discuss and manage the vaginal route. There may be women that have had a hysterectomy, and so that we go into different types of scenarios without a uterus, and or now the pendulum has swung to hysteropexy, which is uterine suspension procedures, where we can actually do a particular procedure where we take sutures transcutaneously and we can place them through the ligaments deep in our pelvis and connect them to the cervix, the bottom of the uterus, and suspend the uterus. So we're preserving the uterus, not doing a hysterectomy, and doing a uterine suspension. So I start talking to them about that, and doctors, they're like, "Doctor, I'm so confused." And I'm like, "Yeah, sometimes I confuse myself." So I try to, let them know that we have the options, and then I steer them to what I think that they would be a good candidate for, and depending on their anatomy, and depending, like I said, on all the other factors. So we have a lot of different approaches, which is nice. That's the beauty of our specialty, that patients not pigeonholed into one surgery. Patients go in for gallbladder, they go in for one surgery. We have different ways to offer pelvic reconstructive surgery and different recoveries. And it, like I said, it all depends on the patient's needs, their medical comorbidities, and of course their age is a major factor. We have an older patient population, so we may be offering them something different than we do a younger patient in their 40s to 60s who are sexually active and physically active.
So yeah, so it's a big outline, right? And it gives you a lot of options. And I think that's really important for the women that are watching this show, is that, one size doesn't fit all. And that that's why it's so important to have that relationship with your specialist, someone that is like yourself, a urogynecologist, or someone who is a urologist that then went off and did female pelvic floor training, to be able to have that conversation to say, hey, what's the best way to address how I'm feeling right now and the conditions that I'm presenting. And so we talked a little bit about the surgery side, and you kind of walk yourself through you walk the patient through this little algorithm. All right. And then if they say, hey, I want to avoid surgery right now, what are the things that you're doing in your office that keeps them out of the OR, but can still give them a better quality of life?
So definitely depends on their symptoms. I walk them through, first and foremost, vaginal estrogen therapy. It's not going to heal or cure the prolapse. However, it can help the integrity of the vaginal tissue. So that's first thing for either side, whether it's conservative management or surgery. And then we walk them through pelvic floor therapy, whether they do it at home. They actually get the guidance and the training from a pelvic floor specialist. And we also have a special chair by BTL. It's called Emsella, Emsella. What it is the electromagnetic impulses that are in the as a cone in the middle of this chair, where the patient actually just can sit on the chair and have a 30-minute session and have repetitive contractions of their pelvic floor musculature in the form of like a Kegel exercise. And about 10,000 of them occurs over that 30 minutes. And so they can come in repeatedly, like every, twice a week for every 3 weeks. And thereafter, I tell them it's kind of like a gym membership where they come in and it's a passive way. They don't have to do the exercises. They just sit there on the chair. Yeah. Bring your book, watch a little movie. Yeah. So it's great. So they have that available. Yeah. They have that available for them. And they have these, kind of, well, I don't know if I can do this. This is time consuming. So I walk them through that. Do you want to go to a pelvic floor specialist, or do you want to just come here a couple times a week? And then you can come as often as you'd like. And that's really helpful for women that also have incontinence as well, because they're actually helping to restore those connective tissues and the muscles that just help to tighten those connective tissues around the pelvic organs in and surrounding the bladder and the bladder neck.
I mean, to sum it up for the women that are thinking like, oh, like, what is this? It's basically, it looks like a disc it looks like an ottoman, a mini ottoman that you sit on, and it's going to vibrate like a lot, basically. I mean, it's just like, you imagine this thing put on hyperdrive, 10,000, shakes, in seconds. And what it does is it's tricking your pelvic floor, basically your inner core, to clamp down, right? I mean, that's we're like, so great product. One of the things that you have, part of that innovative solution that you have, that and even pre-surgical, post-surgical, right, helps people recover.
Yeah, there's a lot of women that will come in afterwards and have it after their surgery and use pelvic floor therapy or the Emsella. We also have Thermiva. Thermiva is a radio frequency heat therapy, has been out for a number of years, where we introduce intravaginally. So it's a little bit more intimate, a little bit more invasive, but it's painless. And the heat therapy can actually contract the tissue and recreate new collagen. And we have used it in some women who have some more mild, subtle pelvic organ prolapse, that it can help with lifting a cystocele or rectocele about a degree. So women who are very adamant that they want full, disclosure, they want no surgery, they want complete conservative therapy, Thermiva helps with the connective tissues and the vaginal mucosa, and it really can help with support, and also with some mild to moderate urinary incontinence. It's a series of 3 treatments.
So I was just asking you.
Yeah.
You answered my question. Yeah. I'm like, okay, yeah. So what does that mean? So how many treatments?
It's a series of 3 treatments, and they come in for about 30 to 40 minutes for the procedure. It's gentle heat that is passed through a probe intravaginally, and then they can come once a year for what we call maintenance therapy. So it is a nice, non-invasive way to offer some support and kind of, I don't want to say kick the can down the road, but give you a little bit of time. Say they're very busy with their life. They they have kids they're raising. They're busy at home. They're busy at work. They don't have time for a 6-week recovery from surgery. They want something that can help them now because they're having some irritative symptoms. Nothing like major, but they're having enough where it's bothersome condition, it's affecting their quality of life, and so they can have something. And I tell them you can dovetail the Emsella with the Thermi. You're kind of getting it from both angles. You're going to help the muscles, and then the Thermi helps your connective tissue and your vaginal mucosa. So because your pelvic floor is a dynamic organ, it has multiple layers, and you're treating, all the different layers that help support your organs.
And probably the best way to describe that device is that it kind of reminds me of a larger curling iron, right? It's like but it's about,
Or opposite, smaller curling iron. The Thermi is very small, has a very small, and it has a sensor at the end of it. So it has this little curvature so that you can move the sensor along the vaginal wall. It's a wand. So you're delivering the heat, and you're moving it because it's radio frequency heat. So you don't want to make an arc, and you don't want to leave it on the tissue because then you can have a patient, you can burn the skin. So you want to move it gently and transfer the heat. So you warm up the tissue enough so it goes deep into the dermis and helps to recruit collagen, new nerve endings, new blood supply, getting a whole new vascular changes to the vaginal mucosa. So it's definitely comparable to a probe or an instrument or a wand that you insert vaginally. Just like our laser, we have the Mona Lisa Touch. Don't really offer it for vaginal reconstruction or vaginal prolapse, more so for vaginal atrophy, and kind of steer towards patients who need, a little bit more support, maybe at the bladder neck for their incontinence, and some support to the vaginal tissues. But that looks like a probe, like a curling iron size. And and then that's inserted intravaginally, and that just, you turn that and you fire the laser, and it's cylindrical. So you just turn it, and that's about a 5-minute procedure. And we do that series of 3 treatments, 6 weeks apart, to generate the tissue, helps collagen production, helps the vaginal mucosal changes, helps restore blood supply and nerve endings as well. And so we have these in our office. And so they're very popular for those women that want a conservative approach. Oftentimes the laser is very popular in those women who suffered from breast cancer, who are not candidates for estrogen. And so that could be a great patient that we offer that.
I love it. Okay, so one of these a buzzword, hot topic, women's magazines, Instagram following, O-Shot. Okay, what's going on with that? What is it? What are you doing, and why are you doing it?
So the O-Shot, at its term for orgasm, and it is very simply platelet-rich plasma, discovered and developed by Dr. Charles Reynolds, and very bright internist down in Alabama, who found that using platelet-rich plasma, which is rich in growth factor, delivering it back. Yeah.
How do I get what is PRP? It's a buzzword.
Yeah.
I have no
PRP.
idea.
So
what are we doing here?
Yep. So so I tell the woman it's your blood. We draw your blood like we would a blood test. We take that tube of blood, we spin it down in a special centrifuge, so it's concentrating the platelets. It goes through a 8-minute spin, and then once we get that tube, there's just the platelets that are left at the top of that tube. We draw that up in a 10 cc syringe, and that's now what we use to inject back into your own tissue. So it's your own blood, the PRP, rich in growth factor, help accelerate the production of new cells in the area that we injected. So podiatrists use it, orthopedics use it, it's used in plastics, and now in the arena of urology and urogynecology, it's become very popular. So we're not only using, we're using for the O-Shot, that's our injection underneath the bladder neck, that plush area of nerves and blood supply underneath the bladder neck. that help sort of the G-spot area that helps recruit new healthy tissue, recruits new nerve endings. It increases sensitivity, increases the vascularity, so engorgement. And then we also inject it underneath the clitoral hood and in the glands of the clitoris itself. Again, bringing blood supply to that area, increasing sensitivity, and so allowing women to achieve orgasm quicker, so have that less refractory time, and achieve it more often.
So what does that, conversation look like? How do you get into that? Or that's, it's definitely intimate, but you explained it in a really great way to hopefully make them feel comfortable. So what does that interaction look like?
So the nice thing is we have a billboard or like a little banner in our waiting area. So it prompts the question every single woman. I mean, I have my little 80-year-old women asking me, which is so great because I love talking to them about the sort of intimate part of their body. And so I said the O shot. It's trying to achieve orgasm and improving your orgasmic pleasure. So and then we just start having the conversation. Well, I want the O shot because it says it'll help with incontinence as well. So there's a small few pilot studies that it can improve in 25 to 50% of patients, depending on the severity of their incontinence. It can improve their incontinence because it does help to rebuild collagen. So you can manifest a improvement in the urinary symptoms from having the O shot. But I explain to them depending on their severity, the degree of their incontinence. But really the message is to help to improve overall sexuality, overall stimulation and sensitivity in the vaginal and clitoral area. And so to have that conversation for me now that I've been offering O-shot for 5 years, it's become a lot easier. It kind of rolls off the tongue. I get excited when people ask. I want to be able to offer them, improvement in their sex life. I think women are, they're saying that 60 is the new 40. Women are, much more sexual. I think this day and age that they're wanting to know what they can do. They're listening to podcasts. They're getting educated, and so I think that it's something I want to tell them. And if they don't talk about it, I ask them because we always have a question on our questionnaire about their sexuality, if they're sexually active, and if not, why. And so we kind of dive into the reasons why they're not. And so then that will allow me to open up that opportunity to talk to them about
a lot of stuff, right?
Yeah. So it's like an onion. You just kind of start peeling the onion. You only have so much time in your office, but if they do have these things that we uncover, we can make a separate visit. And a lot of times it's their pelvic organ prolapse. It's causing them to have, sexual problems because they're embarrassed, or they don't want to hurt something, or they don't want to puncture something, or they're afraid that, they're going to have an injury, or that, it's going to get worse. So I have to reassure them on those levels. But once they are allayed their fears that nothing's going to happen with sexual activity, I tell them they can continue to have it. They say, well, it's kind of uncomfortable. And then we uncover some of the reasons why that. Because O-shot not only can help with lubrication as well. It helps lubricate the tissue as well because you're increasing the blood flow, which helps with the transudative production, the transudate effect. So meaning the liquidization in the blood supply. So more blood supply, more vaginal secretions. So that's an option for them too.
It's a plus all the way around, right?
Yeah, it's a plus all the way around.
I think we should lobby for insurance to pay for it.
I agree. But women will pay, and I go through that discussion too, which it's not covered by insurance, but it is invaluable when you're talking about your intimate wellness, and I think your husband will agree that if you get this shot, then he would be happy to pay for
He'll
that.
Pay for it.
He'll pay for it.
Listen, that's what you want to be promoting here.
Absolutely.
Give this to your husband. Give this to your partner. To your significant other, whatever that is. And because they're going to pay for it because they're also going to benefit from.
They're going to benefit as well. most of the time the women come in because they want it for themselves. They truly do. They truly want to have a good sexual encounter. They want to be able to, and then of course too, they want to be able to, please their partners as well. But I think most of the time the women want it for themselves, which I think is great.
Well, it's good. It's a win-win, right? So so everyone's going to win. Internal, yourself is going to win by feeling better about yourself. Your partner's going to also be able to benefit from that. So what some of the other like trailblazing things that you've been doing within your practice, I think you have brought on uh, HRT, right? Hormone replacement therapy. Talk to me a little bit about that and like who is a candidate for that?
Sure. So I went through because we have a captive audience. So when I'm seeing these women, unfortunately, a lot because of the Women's Health Initiative and the issues from that study and the risks of breast cancer and heart disease and stroke that were outlined over 10 years ago, a lot of women abandoned or their OBGYNs just did not and neglected to offer them hormone replacement therapy. And so, unfortunately, we have a lot of women out there that have not had hormone replacement therapy for greater than 10 years. So those went a long time. And so those women have suffered and they have, gone through the vasomotor symptoms, the hot flashes, night sweats, and so forth, but they're losing their libido, their vaginal integrity. So they're having dryness, painful intercourse. So we really explore with those
Mental
women more.
clarity,
Yes, I mean
sleep,
all this,
sleep.
all the sleep. So getting into bioidentical hormones and offering testosterone, it's kind of a different animal than estrogen. So these women may be at risk for introducing estrogen back into their systems, but they can use testosterone, and we use it in the form of pellets or creams because there's no FDA approved testosterone for women. So testosterone can be an option. Bioidentical creams that we can offer, applying it on transdermally onto their skin, or even just local application of estrogen therapy is very popular in my practice. And I think every single woman walks out of my practice with some form of estrogen, whether it's a cream, an ovule, or a tablet that they can insert intravaginally for their overall pelvic wellness.
Yeah. How is that going to help those ladies? So if they're, like just from the estrogen side of things, what's benefiting?
So the women that are under 10 years of age or they are going through menopause, we do explore estrogen therapy with them in conjunction with progesterone if they have a uterus and estrogen alone if they don't. Because we now know that estrogen is safe and all the disclaimers from the Women's Health Initiative have been, contraindicated and debunked. Absolutely. And so now we are offering estrogen, whether it's, oral form, we can do transdermal patches. We still offer estrogen in a pellet form. So we can dive into what the patient's needs are. If they are non-compliant and they can't take a pill every day, do they want to go on a patch or they want to do a pellet? And so estrogen can help with so many things. Even just going through menopause myself, I'm realizing like you said, from your visual disturbances, mental clarity, headaches, skin changes, as far as your palpitations, night sweats, hot flashes, gastrointestinal issues, bowel issues. There's other skin conditions, dermatologic conditions that are associated with it. Tinnitus, ringing in your ears. These are all things that women don't realize that are related to menopause. And so getting them back on a hormone replacement, their libido, all these things have been what women have been suffering with. They just, haven't been able to, orthopedic issues, bone aches, musculoskeletal issues, arthritic changes. I mean, every single condition that you may experience could be due to menopause. And unfortunately, women were like, well, they were told, oh, it's just, is it menopause? Well, it could be. It's hormonal, and there's not much. You're just getting older, and there's not much you can do about it. Now you can. And I think that individualized approach is key. Each patient is individualized in our practice. We go through a whole panel of their hormones and do blood work. And then we do a very elaborate questionnaire and kind of what their needs are. And so that really helps tailor each patient with what they need as far as hormone replacement therapy.
That's great. And it's really important that you are looking at correcting these type of issues, and then you're offering full area of solutions just based on how the patient presents. So that is absolutely fantastic.
Yeah. We're also doing, supplementation too. So they need vitamin D. We look at their vitamin D. They may need B12. So I think their vitamin supplementation is key, and their diet. I think diet is key. We've integrated a weight loss program as well.
Yeah, tell
So
me about that.
diving into
What's going
so
on with
so
your woman that is
yeah
frustrated. She's been working out. She
yeah
hasn't been able to lose that weight. First and foremost, you get their hormones
get their
on track.
hormones in check.
That's
But
a
women,
that's the first thing.
postmenopausal women are insulin resistant. We have more insulin resistance. And so as we get older, we are not producing insulin. And so we go through these changes where you get this, what we call metabolic syndrome, where you get this propensity of weight gain in the abdomen because your insulin is not being delivered into your body.
Right.
So
Those are the number one receptors for a woman.
so you need
Right there.
So you need, unfortunately, it's something that I think is breakthrough with our GLP-1s, our semaglutide, tirzepatide, your Ozempic, your Mounjaros, in a low dose compounding formulation, or even our FDA approved formulations of the GLP-1 agonists. We're delivering that back into our bodies, and we're noticing that women they're producing insulin, and they're able to lose the weight that they have not been able to lose during their menopause. And so because of this,
it's a fancy way to, trick your body, right?
yeah,
Genetic.
you're delivering the actual hormone that is excreted in your gut. And so you're turning on your production of insulin, you're allowing your body to metabolize the food correctly. And so that you don't, and helping your cortisol level, and it's helping all with your adrenal gland. And so, so we've started that program about 6 months ago, and my menopausal women have done so well. We see so many happy patients, and and people ask, well, how long do they have to be on it? Well, the good thing is these women who were never really overweight through their life, who became overweight through menopause, can go on it for a finite period of time to lose the weight. And then we also talk to them very closely with diet, increasing their protein in their diet, and continuing to exercise and doing weight-bearing exercises. There was the day where it's just aerobics. Everybody did aerobic exercise and no one really lifted weights. Women didn't lift weights. And now we've changed in the decades now, and with the Richard Simmons and all that, and people were like running and doing all this cardio. Now we're weight training, and so we're really giving patients guidance on how to do weight training and helping their bones, helping their muscles, but also keeping the weight off by weight training and increasing their protein in their diet. So we definitely give them an elaborate diet program and help them with some supplements.
There's no magic bullet, right? But when you put it all together, and especially when you can offer, different solutions like you offer, then it's that kickstart to, get them on the pathway of being healthier, shedding some of that weight. It's just positive all the way across, just from, bone structure, weight bearing, and the fact that, they're all of these areas are going to be actually better for their internal, better for their heart. A lot of positives from it. And you mentioned something though, is like, really important to be, low and slow, right? That I think it's is that you put them on a proper dose and you put them on the lowest dose possible, because they didn't gain the weight overnight, right? So we don't want them to lose the weight overnight.
We want a gradual weight loss over time. And so I tell women, don't expect, I want half a pound, if at all, a week or 2 weeks. And so the slower that they lose the weight, it'll stay off. The longer it'll stay off, and it'll be real weight loss, not just water weight or just kind of, from eating extra sodium the night before. It's going to be actual weight. And we do a very structured, we do a body composition analysis, getting their weight in grams of, fat, water, and muscle. And so we get a percentage for them, and we show that, and that we don't want them to lose muscle. We want their muscle mass to be greater than their fat mass. And we give them a diagram and we show them where they should be on the ratio, and we want to stay that way. So yeah, slow and steady.
Because if you lose that muscle, right, you lose then the ability to burn calories. That's what it
Absolutely.
is. You're turning off those little furnaces. And if you lose those little furnaces that are going to burn your calories, then you're going to find that, your caloric intake even has to go lower. And we want to definitely avoid that.
Absolutely. Call that skinny fat.
So what other things that I'm not familiar with that you're thinking about doing or that you're doing right now, that you would consider to be, innovative in your practice?
Yeah. So, we just, we elaborate more on platelet-rich plasma. We're using that more for women who have vulvar conditions that have been untreated for many years. One of them is lichen sclerosis. I see a higher patient population of women who have this condition of the outside of the vaginal vulvar tissue. So women think it's just atrophy that they're suffering from, which is the thinning of the vaginal skin, when it's actually this other condition. And so we're using platelet-rich plasma. We're injecting it into the tissue to help actually give them remission from this very serious, benign condition, but very serious condition that can cause painful intercourse, itching, burning, and irritation, and other quality of life issues. So PRP we're using often. We're using it for filler. We're using it naturally to help fill the tissue for women who, for cosmetic reasons in gynecology. So doing a lot more cosmetic gynecology surgery. So we're kind of staying on the forefront of that. We're hearing women and what they want, and we're offering these other options.
Well, which is fantastic, and I think that's why it goes all the way back to having those conversations, right? It's that if you can't feel your partner, that's probably due to the fact that maybe you had three children, vaginal delivery, and now you're having a little prolapse. Well, you can address that. Not only can you fix your prolapse, but you can also tighten their vaginal canal so that now they get that sensation back again. And you probably equate it to turning the clock back to what age? How do you frame that? Is it 20? What do you want to be? You want to be 20, 21, 25?
Before kids, BK, before kids, they want to be able to have, their pelvic floor and their vaginal integrity to be what it was when they were before kids. And so we go through, and a lot of women ask. I mean, it is amazing. Once you get it out there, we're doing more education on our Instagram. We have a lot of YouTube educational videos on vaginoplasty, labiaplasty, perineoplasty, and all these conditions, or at least these surgeries that we offer, women suffer from. They just don't talk about it. And now that we have that information out there, they're coming in and they're wanting to know more. They're wanting to know how can this be fixed? How can it help me feel like I can feel tighter and feel like I can, have a better, more sexual, intimate relationship with my new partner, particularly women that are getting remarried and finding, in their second partner, our second spouse, they're kind of rejuvenated, if you will, and they're in their sex lives, and they're finding that they want to be able to, have a better sex life. So we go through things and discover and find that, it's the vaginal laxity that's not allowing them to have that friction to achieve orgasm. And so these are things that we have to really discover.
And you can fix it. That's the best part. And you're going to be down there and you're going to be in the operating room. And so it's really important. So next time I come in your office, I'm going to see a roll up. It's going to have a crown, picture of the crown. And you're going to say, ask me about BK. And then
For
they're going to be
kids.
thinking
Yeah.
hey, do you guys Burger King, right?
I didn't think about that way.
But we are
Yeah.
gonna be able to give it your way, right? So you customize it, directly for them.
Yeah.
So yeah, that was when you were saying
I think
about
we're
the
onto
BK.
something.
I'm like going, bingo. All right, trademark that.
Yeah.
And it's really about that discovery and for women to
Right.
open up and be able to have those conversations. So.
Mm-hmm.
Final question, if I'm a woman and I'm hesitant to seek help, either, due to embarrassment or fear of the treatment, what advice would you give ladies out there that are feeling this way? What would be your coaching moment for these ladies?
Well, number one, they're not alone. And I don't want them to suffer in silence. I think it's very important that they seek a professional who specializes, like myself, in this field, and seek them out because they don't need a referral. They can call, make an appointment. And the nice thing is we can just discuss things. You're not going to have any intervention when you come in. We're going to have a consultation and an exam. And I think that once we can address the problem, know that they can be comfortable with what's going on because they're not alone, and there's other women that have this, and this is a very common condition, and and there's a lot of treatment options for you that are tailored to you specifically. And so that's really important, that you don't need to suffer in silence, and you can regain your confidence, and you can have a better quality of life, because that at the end of the day is what it is. It's your quality of life.
Absolutely. And that's why we're here, right? I mean, we're in this space, we're in this field because, uh, women give so much to us, in society, you being one of them. And how I look at it on our side is, how can I give back to the community and the space that I work and love to work in. So we'll close with that. Dr. Pezzella,
Thank
thank you
you.
so
Thank you,
much.
Rob, so much. I really
Thanks
appreciate
for
it.
sharing your expertise. I mean,
Yeah,
I think
I appreciate
women
it.
are going to get a lot of great lessons learned here. And it's certainly true that your passion lives, in what you do. You can follow your Instagram. I enjoy it. We enjoy it in the office.
Yeah, thank you so
You
much.
you guys are, professional, but also fun. And, looks like a really great place to work.
Yeah.
And I'm sure that your patients are very fortunate. So if people want to see Dr. Pezzella out of town, if they come in, from out of town, you certainly would, I know you'd be happy to see them. Are you doing any consultations via telehealth or any of that?
I mean, we definitely have had situations where there's, because I'm on physician locators for different procedures that I do that are not, so patients come in from Alabama, Tennessee, Florida, especially with the cosmetic gynecology. I just did a patient today. She's down in Georgia. So I don't mind doing a consultation over the phone, but at the end of the day, probably need an exam if we're going to do any kind of surgery. So
Right. But it's always a great place to start, right?
great
And,
place to start.
especially for those out of town
Yeah, we
patients, because
appreciate.
we get a lot of people that, around the country that will be watching this and saying, what, I'd really like to go see you. And that's like step one. Let's make sure you're a good candidate for what you're trying to treat.
Right.
You and your practice, and then you take it from there. So That's a great way to end. Thank you so
Thank
much.
you.
We'd love to
Thank you,
have
Rob.
you on the program again, and
Yeah,
certainly
I love it.
make it all possible with our sponsors, I've7. So we're
Absolutely.
trying to advance wellness just like they are. And Dr. Pezella, thanks and have a great night.
Thank you. You too, Rob. Appreciate it.